Kaushik Goswami obtained DPM and MD Psychiatry from Central Institute of Psychiatry, Ranchi. In 2008, he won the Siddharth Memorial Award at Eastern Zonal Conference of Indian Psychiatric Society. His paper on neurological science in bipolar disorder. In 2010, he won the Best Post Award at the Joint Conference of NIHANS and Royal College of Psychiatry, UK. In June 2011, he won the Travel Award from Royal College of Psychiatry to attend their international conference at Brighton, UK and present a paper. In June 2011, he won the ICMR Travel Grant to present a paper at the International Conference on Bipolar Disorders held at Pittsburgh, USA. He has published 6 papers in national and international journals and has presented papers in various national conferences. He is now working as senior resident in NIHANS, Bangalore. Sir, Dr. Kaushik Goswami, we cordially welcome you to start this session.
Pharmacological intervention in alcohol dependence syndrome. Till now, you have learned about various aspects of alcohol dependence, and by now you have understood that this is a complex problem which has biological as well as psychosocial underpinnings, and hence a multi-pronged approach is very essential. And pharmacotherapy happens to be one of the approaches in treating alcohol dependence syndrome. As you must have understood that neither psychosocial interventions nor pharmacological interventions is exclusive, and one cannot be effective completely without the other. So we will talk about pharmacological interventions. Before that, I would just talk a little bit, as you all know, about the magnitude of the problem, that it is the 4th leading cause of disability in the age group of 15 to 44 years. That's according to WHO. And prevalence is pretty high. It is 21.4%, that is in India, whereas cannabis is only 3%. So you can understand that it's quite a major public health problem leading to a lot of burden as far as our social and economic structures are concerned. Before I would go into the details of pharmacotherapy, a very brief idea about how alcohol works in the brain. That will help us understand why we choose certain agents. So we all, in the first presentation today, we had understood about the reward circuit that is involved in the regulation of motivational behavior. Addictive drugs basically increase dopamine concentration and transmission in the reward circuit, that is from the ventral tegmentum and to the nucleus accumbens. And dopamine release also increases in nucleus accumbens in response to reward-seeking behavior and anticipation by around 3 to 5 times. Again, craving, which is there, that is due to supraphysiological activation and results in memory traces. So these memory traces which are there due to increased dopamine secretion, when we are exposed to cues in the environment which are related to alcohol, for example, the bottle or the bar or those friends with whom we used to drink, what happens is that our dopamine cells in the brain starts firing more and more, and then we feel the urge to drink. So I'm just giving you a very brief and overview of how various manifestations of alcohol dependence occur. And tolerance again is a very biological phenomena where if there is increase in dopamine secretion in the brain, there is down regulation of the receptors, that is number of receptors go down and the sensitivity of the receptor to dopamine also comes down, and hence we need higher amount of alcohol to produce the same effect. Again, this has been shown, the reward circuit. Now when we talk about pharmacotherapy, there are certain steps of which most have been covered: identification of the problem, then intervention, and then detoxification. Now, this detoxification is a very essential step. Detoxification means when a person who is adapted to taking alcohol, that is his brain is adapted to this particular substance, stops taking the substance. There is certain manifestations in the body, which is known as withdrawal. So to help the person go through withdrawal, and when his body is again reverting back to the state when he was not taking alcohol, is known as detoxification. Then comes the further rehabilitation, that is helping him to stay away from alcohol, where the functions of relapse prevention comes in. Changes that occurs in the brain, that is neuroadaptation, and when he finally stops, again the brain has to go through the reverse changes, so that takes time. Certain cases where there is very severe dependence, where there are other comorbid, say medical illnesses, for example, apart from alcohol withdrawal, the person is also having hepatitis or jaundice, or say the person is in delirium, or the person had seizures, withdrawal seizures, which indicate severe withdrawal. He needs inpatient treatment. So the first step is to understand where you want to treat the patient, right? After that, we have to understand what to do. The first is supportive. Before giving the medications that needs to be given, you have to support the patient. That is, you have to correct the fluid and electrolyte balance. You know that in alcohol withdrawal, there is more often than not, there is electrolyte imbalance, like sodium, potassium. There is sodium level goes down, potassium level goes down. These leads to in turn delirium. So we have to understand what is and see what is the current status and need to manage that accordingly. And fluid supplementation is also very important. Apart from that, parenteral thiamine or vitamin B1, as has been talked about the previous speakers, very important because vitamin B1 deficiency is supplemented with diazepam either 5 milligram, lorazepam 1 milligram, and chlordiazepoxide 10 milligram. This is per unit. Unit is 30 milliliter of alcohol. So suppose a person had taken 1 liter, or normal intake is around 1 liter per day. We can understand how many, say 720 ml, that is how many 30 mLs are there. Based on that, we can calculate the dose. Then there are two kinds of treatment. One is fixed dose, one is symptom triggered. Fixed dose is where you keep on giving a fixed amount of, say diazepam, 20 milligram every 6 hourly for 4 doses, then 10 milligram. So the dose is fixed here. The other one is basically whenever there is severe withdrawal symptoms, you give according to the symptoms. So you can calculate that by the CIWA scores, that is the Clinical Institute of Withdrawal Assessment. Then there are two kinds of benzodiazepines, actually long-acting and short-acting. Both have their own advantages. Whereas long-acting benzodiazepines make the withdrawal management quite smooth. You can taper off easily. The withdrawal from benzodiazepines is low. Chance of withdrawal seizures is low. The short-acting benzodiazepines are more preferred in elderly and those who have medical comorbidities, those who have less, clearance. Clearance means the amount of drug that can be removed from the body. So in elderly people, that becomes less. So we use molecules which have shorter half-life. Now this is another, apart from benzodiazepines, carbamazepine, this is another molecule which is used in alcohol withdrawal, management of alcohol withdrawal. This is actually an anticonvulsant used in epilepsy. And it acts by inhibiting voltage-dependent sodium channels and activating potassium channels. And it has been seen that carbamazepine suppresses withdrawal-induced kindling. Anyways, I'll not go into detail. Which is more important that in some studies it has been proved superior to lorazepam for preventing withdrawal symptoms, and it has been used successfully in such patients who has multiple alcohol-related withdrawal. So withdrawal, then again managed, then again there was a relapse, and then again withdrawal. So this kind of patients. Apart from that, sodium valproate. This is another anti-epileptic. And this also acts on sodium channels as well as GABA. GABA, as you have seen, gamma aminobutyric acid. And this also has been shown to act on alcohol withdrawal symptoms. And also, additional advantage is that this can prevent seizures also. So in that way, valproate is also tried. Then there are newer treatments which are becoming more and more popular these days for alcohol withdrawal. Particularly, I'd like to talk about baclofen because in my institute currently, the addiction center, baclofen is used more and more to manage alcohol withdrawal and very effectively. Apart from that, gabapentin, tiagabin topiramate, gamma hydroxybutyrate, these are also used. Now, baclofen is a GABA B. B is a basically receptor subtype. GABA B receptor agonist, and it is basically the efficacy is in it facilitates GABAergic transmission. In this way, it affects alcohol withdrawal symptoms by enhancing the effect of GABA in the brain, which is an inhibitory neurotransmitter. Thus, if you increase GABA in the brain, the excitability of the brain will come down, and hence the withdrawal symptoms will come down. Again, various is involved in the reward circuit in facilitating dopaminergic transmission in the reward circuit. So, opioid system is indirectly involved in alcohol taking behavior. So, if we can block opioid receptors, we can block the effect of the reward seeking behavior, the reinforcement. So, that is the premise of using any opioid antagonist, and it has been seen that it is effective in early age of dependence where there is family history of alcohol dependence, high degree of craving is there.